Assalamu alaikum wa rahmatullah. I apologize. Yesterday, actually, I was just stuck somewhere, so I couldn't take the class yesterday. We were doing advanced trauma life support, and we just finished the primary survey, the secondary survey, and today uh, we will have some discussion about trauma, airway management in trauma patient. So generally, the basic principle will be the same, but you remember one thing that mills, you never forget to mention or think about mills, manual inline stabilization, and you have to consider cervical spinal injury unless it is ruled out, okay, by nexus criteria or something. And because it will be a condition of stress and a patient will be considered as full stomach, so there will be chances of aspiration. Then there will be another problem is there if there is involvement of face or bleeding coming towards the airway, it can create problems. Okay, so you just have to adequately assess the airway. You have to recognize the need for an early airway intervention. Okay, so if you fail to do so, then you may lose because for example, if there is airway bleeding, if you delay the intubation, so maybe later on it will become even further difficult. Similarly, you have a patient with inhalational injury or so with the development of airway edema, then it will becomes more difficult for you. So these are few basic things. Mm, okay. So can anyone just tell me practically what problem we face? Like what will be the challenges? Can anyone speak out? Yes, Sabah, would you like to
In
speak?
sir, in trauma patient,
Yes.
sir, the main concern is first of all there is difficult airway and difficult unstable cervical spine.
Okay.
Then patient is full stomach, and patient may have uh, CNS injury to the head injury or other chest injuries, and maybe intoxication.
Most of the time you will be managing the airway. For example, in the if you are managing the airway in the emergency, the situation will not be familiar to you, okay, as an anesthetist if you are being called to manage there, and especially if there is like polytrauma and the other injuries are there, then it will become even further difficult, okay. And another thing is that you are not sure because maybe if you are managing the airway early in the management, then it will become even more challenging. If once the patient, for example, there will be two scenarios that you are managing uh, a patient who was optimized or evaluated and they have been ruled out, and now the patient is coming for some elective surgery, things will be a little different. But if you are being asked to have to secure the airway in the emergency, then it becomes even more difficult. Okay. And with reference to maintaining oxygenation, and because if the head injury is there, then it becomes even more important, and there will be more problem with reference to patient may develop fits. Patient because conscious level is deteriorated, then there will be more chances of aspiration. So these things you should keep in mind. The same things you will find written here. So, like with reference to head injury and facial burns. Okay, so these things you should be thinking. The otherwise the basic principle will be the same. There is not much difference in the other way. Then another problem is that, for example, if the patient is hemodynamically unstable, then the airway management will become a little more challenging with the use of the medications. Okay, because if you try to give any other anesthetic, for example, you want rapid sequence induction, and you cannot use the propofol or, for example, thiopentone, then now you have to get a balance how to have the intubating conditions, and so you need to have other medications like etomidate, for example. Uh, Again, ketamine will be a controversial, because if you are using a combination, if you are using small dose, maybe you can give. But if there is head injury, it can increase intracranial pressure. Okay, so these things will make your management further difficult. So with reference to maxillofacial, as I told you, sometimes you don't have opportunity to intubate, and maybe you need to have the surgical airway with the cricothyrotomy. Okay. So you can see the pictures here how facial fractures can be associated with hemorrhage, swelling, increased secretion, dislodged teeth, which can cause additional difficulties in maintaining a patent airway. Okay. Fractures of mandible, especially bilateral body fracture, can cause loss of normal airway structure support and airway obstruction. Then it will be even more problematic to have, for example, mask ventilation. You know how to have mask ventilation in such patient. So this will be an important thing. Uh, Okay. So neck trauma will cause further problems, like penetrating injury to the neck can cause vascular injury with significant hematoma, which can result in displacement and obstruction of the airway. Not only now, the hemodynamic challenges will be there, and if the bleeding is in the place where you have to secure the airway, then it can cause the distortion of the anatomy as well. So these will be two difficult things. And especially even with the blunt or even penetrating, it can cause disruption of larynx or trachea, so resulting in airway obstruction or severe bleeding into the tracheobronchial tree. Even it will be very challenging to have the even the tracheostomy in such cases if it is lower down. So then it becomes a nightmare for you. Okay. Neck injuries involving disruption of the larynx and trachea and compression of the airway from hemorrhage into the soft tissues can cause partial airway obstruction. Initially, patients with this type of serious airway injury may be able to maintain airway patency and ventilation. However, airway compromise suspected, a definitive airway is required. Okay, so maybe initially you can manage according. There will be a wide variety, but it will become a very challenging situation if you need to. Even I can bet that even making doing the tracheostomy can become difficult if you have neck injury. Okay, so although laryngeal fractures rarely occur, they can present with airway obstruction. So there will be hoarseness, subcutaneous emphysema, or some palpable fracture, and there will be severe pain. So complete obstruction of airway or severe respiratory distress for partial obstruction warrants an attempt at intubation. Flexible endoscopic intubation may be helpful in this situation, but only if it can be performed promptly. If intubation is unsuccessful, emergency tracheostomy is indicated. Okay. So if you will have any doubt, you will in any way, if you are trying to secure the airway, the surgical tracheostomy should be ready. The surgeon should be on board. Okay. Similar things, complete penetrating trauma to the can be overt and require immediate management, complete tracheal transection or occlusion of the airway with blood or soft tissue can cause acute airway compromise requiring immediate correction. Just imagine. Okay, so if someone has got the experience, I am lucky not to see the such patients, but in our country, when there is this cat flying season, so maybe someone has managed such case. I luckily I have never seen that case, but you can imagine the in which the cut the throat this neck injury occurs with this cat flying, the what you say, the thing which by which they are using the to have this cat flying. Okay, so this may be a very troublesome thing for you. Okay, so like in primary and secondary management of the patient, uh, you might need to have CT scan. Okay, so objectively, how will you have a sign of airway obstruction? So there may be like obvious sign like hypoxia, cyanosis, or it may be like because of hypercarbia, patient conscious level may be deteriorated with the CO2 narcosis. Uh, so you see, inspecting the nail beds, some circumroll skin. Our cyanosis is a late finding of hypoxia. It may be difficult to detect in pigmented skin. Okay, look for retractions and the use of accessory muscles. Obviously, that's why you will have need to expose the patient, and that time you have to see what's the situation. Pulse oximetry, if the patient does not have hemodynamic instability, maybe the pulse oximeter will be reliable. But if, for example, you have a cold skin, patient has hypotension, then it become even pulse oximeter will not be very challenging. So in that way, clinical judgment will be very important. That's why. Even that's why, remember one thing. Whatever, so this is a message for junior resident. Whatever monitoring gadgets you have, there is no replacement for the physical touch of the patient and physical look of the patient. Okay. So sometimes if the patient is fully covered, then it is difficult to sometimes monitor these things. But always have some evidence of chest rise, some evidence of like proper respiration, ventilation, and oxygenation, even touching the pulse, wherever, whatever source you have. So never miss these things. Okay. So observation and then listen for abnormal sounds like noisy breathing is obstructive breathing. So snoring or gurgling or a crowing sound like stridor can be associated with partial occlusion of pharynx or larynx. Okay. Hoarseness implies functional laryngeal obstruction. So evaluate the patient's behavior. Okay. So if patient is getting aggressive or getting like irritable, this may be an indirect sign patient is getting hypoxic. Okay. So all do not always assume intoxication as they have written here. Okay. So ventilation, ensuring the patent airway is an important step in providing oxygen to the patients, but it is only the first step. A patent airway benefits a patient only when ventilation is adequate. Therefore, clinicians must look for any objective signs of inadequate ventilation. So actually, you have the patent airway, but the conscious level is deteriorated, or there is any cause in which patient is unable to breathe. So even airway space, and then you have to maintain by definitive airway. Okay. So ventilation can be compromised by airway obstruction, altered ventilatory mechanics, or CNS depression. If clearing the airway does not improve the patient's breathing, other causes of problem must be identified and managed. So there are so many reasons for it. Okay, there may be you have to think about it. Maybe patient is not breathing because of conscious level deterioration, because of obstruction, because of patient is having some intoxication. Okay, or as it written here, direct trauma to the chest, particularly with wrist fracture causes pain with breathing and leads to rapid shallow ventilation and hypoxemia. So like you have to consider these things. There will be splinting if there is pain. So there are so many reasons. So you have to rule out what is the exact situation, and then only you can have a better control of airway in that specific condition. Okay, elderly patients and individuals with pre-existing pulmonary dysfunction are at significant risk for ventilatory failure under these circumstances. Pediatric patient may suffer significant thoracic injury without rib fracture. Okay. So, intracranial injury can cause abnormal breathing patterns and compromise adequacy of ventilation. As I told you, that there may be CNS cause. Cervical spinal cord injury can result in respiratory muscle paralysis if it is involving the cervical root. So, then there will be involvement of diaphragm. Okay. Injuries below the C3 level result in maintaining of diaphragmatic function, but loss of intercostal and abdominal muscle. This is the same category which happens if there is either high spinal or total spinal. Okay. So if we have a block like that, so we can identify if the level of the block, if the patient is not able to breathe, most probably it will be involvement of diaphragm. Okay. So of course, maybe it is difficult to identify immediately because as occur in high spinal or total spinal as well. There may be transient apnea in both conditions. even if there is, for example, as they are saying, that diaphragm will be involved even in the injuries higher up. S- there may be transient apnea because of some other reason, like the patient has severe hypotension, and now patient is not able to have the blood flow to the respiratory center. So in that case, it will be a transient apnea. If you correct the hypotension, if you correct the things, with the regain of the circulation, that thing will be reversible. But if you have an injury, or as in the case with total spinal, you will not be able to get it back. Okay. um, so this is the concept you should think, or you should have good concept about it. Okay. Typically these patients display a seesaw pattern of breathing, in which the abdomen is pushed out with inspiration while the lower rib cage is pulled in. This presentation is referred to as abdominal breathing or diaphragmatic breathing. We know that this is paradoxical breathing, this pattern of respiration is inefficient and results in rapid, shallow breathing that leads to atelectasis and ventilation perfusion mismatch. Okay. So objective signs as we of ventilation, look for symmetrical rise and fall of the chest and adequate chest wall exertion. Um, Asymmetry suggests splinting of the rib cage, pneumothorax, or a flail chest. Labored breathing may indicate an imminent threat to the patient's ventilation. So early signs will be there. So you have to anticipate accordingly. Listen for movement of air on both sides of the chest, decrease or absent breath sounds over one or both hemithoraces should alert the examiner to the presence of thoracic injury. Okay, so sometimes it's very difficult to identify, and so it will be a challenging thing. Use a pulse oximeter to measure the patient's oxygen saturation and gauge peripheral perfusion. Note, however, this device does not measure the adequacy of ventilation. Remember this thing. That's a message for post-op period as well. Not only in this case, sometimes you will see the saturation is 100%, but patient is not breathing. So there will be a window period in which you can miss. That's why, like you should be knowing, even anyone, you shift the patient to post-operative care unit. So even you have to teach the nurses, because sometimes they don't know. Because usually in majority of cases, end-tidal CO2 is not monitored in post-operative care unit. Okay. So this is something very important. This is a just message, not only with reference to trauma, it is with reference to general management of the patient as well, that oxygen saturation in adults may take some time if to come down, but it is not guaranteeing adequacy of ventilation. Patient may be obstructed, not breathing, but saturation will be remain there for some time. Okay. Mm, Use capnography, okay, in spontaneously breathing an intubated patient to assess whether ventilation is adequate. So that's what you can put the, if it is available, even if the patient is spontaneously breathing, you can attach it inside the oxygen mask, or there are special nasal cannulas in which there is a mechanism of measuring the end-tidal CO2. Okay. So this is some points with reference to airway, because all of these action potentially require neck. So this is with reference to neck movement. Okay. So whenever they are doing the airway management, it will be challenging to have like securing the airway with reference to cervical spine. Okay. So that's why all trauma patient at risk for spinal, it until it has been excluded by appropriate radiograph, and so we have to consider neck injury, and till the time it is needed, maybe you can delay in that specific scenario. Otherwise, in majority cases, you will do the, like they are showing, you see how they are removing it, even helmet removal. As I told you that it will be, you see, in this way they will remove, they are fixing the neck during this process. You can see this is start, number two, number three, and number four. Okay. Okay. I think this is the our general information which we do for airway predictors of difficult airway. Like here, it will be C-spine injury, severe arthritis of C-spine, significant maxillofacial or mandibular trauma, limited mouth opening. Okay, obesity, anatomical variation with receding chin, overbite, or and a short muscular neck, pediatric patients. So Lemon Law, we all know, look, evaluate, rule of 332, and Malampatti. Okay, this is just a refresher of our uh, basic airway management. Okay, so whenever you are managing suction, oxygen, oropharyngeal or naropharyngeal airway, bag mask, laryngoscope, bougies, extraglottic devices means like supraglottic airway devices should be there. Surgical or needle cricospirotomy kit, endotracheal, different size, different blades, and everything. Okay, pulse oximeter, CO2 detection. So restrict cervical spine motion. This is very important. Don't forget to tell this whenever you are telling about the management of airway management in the trauma patient. Okay. So pre-oxygenate, bag mask or oral airway or nasal airway. If you are able to oxygenate, if you are not able to oxygenate, go for surgical airway. If you are able to oxygenate, we had assessed the with the Lemon Law. If it is difficult, call for assistance and awake intubation. Okay, this is the algorithm here. Or if you it seems easy, so then you will have this rapid sequence induction or modified rapid sequence induction accordingly. If it is unsuccessful, you will consider supraglottic airway. This is again a debate that if a patient has risk of aspiration, should you have this thing? Should you have this algorithm? Or like you can try to have awake fiber optic, awake intubation. Okay.
Excuse me,
So
sir. Sir,
yes.
awake intubation, I think it's not possible in this case because patient is agitated and distracted with
Of
pain
course,
and
if the patient conscious level will not be good, then it will not be possible. Okay, this will only be possible if patient conscious level is there. Okay, your point is valid. You of course you cannot do if awake fiber optic in that scenario. Okay, so I think they have written here awake intubation. What do you think? What could be this? Does it mean? They have not written here awake fiber optic. Can we do awake intubation? Yes, Sabah. What do you think?
awake intubation. That means something we have to give some block or some uh, spray or something like this. But I think it's not possible, sir, in
It's
this
a
trauma.
it's a bit confusing statement. Okay, to be honest, this is a confusing statement. I think this is just because even I'm looking at it for the first time. I have never done this ATLS course. I'm just trying to see majority of the things are the same which we read anywhere else in our anesthesia books. Some of the things are different. I don't know what they are trying to say. This is something confusing. Okay. Mm, so which
Excuse me, sir.
movement? Yes,
But we will
yes,
say, sir, awake intubation. We will in the exam we will say.
yes. If the patient conscious level is there and you want to maintain, you can have this awake fiber optic or awake intubation. Otherwise, you cannot. Okay.
Yes.
Okay. So the thing is that you can have this chin lift or jaw strut, but you will not have the neck movement. Okay. So that's why glidoscope is very helpful to have intubation in these patients. You avoid extra neck movement which you need to do when you are doing with the traditional laryngoscope. Okay. Uh, okay. maneuver used to establish an airway can produce or aggravate C-spine. This is the same uh, point which I was just telling. Okay, and this is like someone is holding the neck. Okay, so limiting the neck movement, and you are trying to have the chin lift. Okay, so this is how they have done it. Okay, so jaw thrust is similarly like you will avoid neck movement. Okay, so these two movements you can do. So someone will be holding the neck, and actually, practically speaking, if we just keep the inline stabilization, yes. Actually, practically speaking, if we have a collar, I think it can also serve the purpose. If you have a hard collar, then actually automatically this neck will be fixed, the movement will be restricted, and then you can do these maneuvers. Okay. So nasopharyngeal airway and oropharyngeal airway actually you should need be careful with reference to head injury, because you see, do not attempt this procedure in patients with suspected or potential cribriform plate fracture. You will enter in the brain. This is one thing. And even airway, if the patient is irritable, sometimes it can cause even irritation, and it can predispose to aspiration. Okay, so this is an important thing. In uh, exams, they are also asking how to measure the correct size of the uh, this one, and there is a pharyngeal and oropharyngeal. Yes, yes, Gopal, you want to ask something? You have raised a hand. You want to say something? Okay.
Yes, sir. Can you hear me?
Yes, yes. Now I
Sir,
can hear you.
hello. Sir, have you ever used the intubating LMA in the difficult situation, the Malampati 3-4?
No, unfortunately or fortunately not. I have not used it. I have not used intubating LMA ever.
And one thing more I am missing, sir. I have studies. There are the two ports in the difficult situation like MP4. We blindly intubate the patient. There are the two ports. One goes in the stomach, in the esophagus, and second one goes in the trachea. And we broke it at the level, at the esophageal level. We blindly insert it. I miss the name actually. In the
No, that
difficult
is combi
situations,
tube.
we
That is combi tube.
combat you. Yes, yes. Is it useful in the difficult situation? Can we
Again,
use,
I
or have you
actually
ever used it?
actually uh, in I unfortunately or fortunately, I again say the same thing, that I have not seen such trauma in which I never use it. This is like Sabah has worked a lot in Shemesi Hospital, so maybe Sabah, can did you ever
No, sir.
use this?
No, no.
So actually, practically, that's why there was a joke that one of the anesthetists, he went to the exam, and the examiner was trying to ask about difficult airway. Okay. And every answer he was saying, no, no, sir, no problem. I will intubate.
Right.
Intubation will have no problem. So actually, some things we don't come across. So like I tell you something, in the exam we tell so many times about awake fiber optic. Believe me, I have never, just it's my chance, it's my luck, I have never done awake fiber optic intubation. Practically atypical sort of intubation with the glidoscope I have done, with anesthetizing the airway, but not a big fiber optic. Pure, you can say that, oh, a obese patient is coming and we are counseling the patient, we are taking consent for awake. This is my chance. This is my luck. So actually, some of the things are hypothetical more than anything else. Like intubating LMA, unfortunately or unlucky, I'm lucky that I don't find that scenario. But of course, as an examiner, as the like as a student, you will never see this thing in the exam. Awake fiber optic, like you are eating food. This should be your answer in any difficult airway scenario. Okay. So these are the basic things. This is also something, I think this is also new. I have not seen this thing. This is IGEL. This is multilumen esophageal airway. There is one COPA, cuffed oropharyngeal airway. I'm just looking, do I find it here? It's not written here, I think. Okay, so we can have just few words about indication, need for airway protection, severe maxillofacial fractures, risk of aspiration, need for neck injury, neck hematoma, laryngeal, inhalational injury, stridor, voice change, or unconsciousness. Okay. Uh, this is with the reference to ventilation or oxygenation, in which tachypnea, hypoxia, hypercarbia, cyanosis, combativeness. This is a part of something, not only one thing. Progressive change in accessory muscle use, respiratory muscle paralysis. This is basic stuff. Actually, this is just repetition or number of things which we do in other cases. Okay. If you are have someone try to use bougie with the glidoscope, is it easy? Can anyone comment about it?
Sir, I think it's not easy, sir, because
Yes.
Buji will not go
The angle
with
becomes like
answer.
that actually with the glido, when you are using glidoscope, use of bougie become difficult. Okay. So this is a practical thing which I face a number of times, because I am not a bougie lover actually. Uh, when I got trained, actually I never use bougie. So we either use a stillet or inna lillah. Either we are not able to intubate, or we intubate with the stillet. So surgical airway, because we don't have mandate for this thing. Management of oxygenation. This, I think I will finish before. I don't know. This chapter is haunting me, so I will leave ATLS because it's becoming like actually the basic chunk of ATLS revolves around identification of the major injuries. Okay, because mainly it is with reference to like uh, it is mainly related to surgeon. A number of things which we are talking, it is related to surgeons. Okay, but of course we have to. So I think we will discuss with shock. I had discussed before as well, but will discuss having some aspects of shock and hemorrhage tomorrow, inshallah. Okay. So actually, the whatever we have studied up till in last 3 4 days, remember one thing: the basic trauma question will be much easier to answer than sometimes we think. The logical thing will be identification of any problem and anticipating. This is one thing. Then you have to always think that airway, breathing, circulation, disability, and exposure. Okay. And you have to be logical. You have to consider about ruling out the immediate need of intervention in some of the problems, like tension pneumothorax, like securing the airway if the patient is apneic, conscious level is deteriorated. So this is the important thing. Then you always have to consider ruling out other injuries, thoracic injury, abdominal injuries, long bone fracture, pelvic fracture. This is the same message which we from where the the first discussion in which I just gave you an overview, the extempore overview, which I told you. I'm just trying to actually read out, and if we important points we can discuss about it. With reference to shock, we will continue tomorrow. But remember one thing with reference to shock, again, identification of the level of the shock. This is one point which is important. and how will you classify, and what will be your transfusion trigger. This is the second thing. Usually, if the patient does not have any like other comorbidity, and patient was all right, you will consider it as isovolemic loss. Okay, isovolemic loss. So there, the concept of 1:1:1 will come. Okay, usually, because sometimes if the hemorrhagic shock is complicating an already comorbid patient with different pathological condition, maybe the approach will be different. That's why you need to change your approach a little bit, and that you will be again, because in shock identification, and then you use this rotom. A lot of time we can follow our uh, yeah, management with rotom. Yes, you can get it. I share this link of, if you have my number, just drop me a message. I will. If are you on my WhatsApp group? If you are on my WhatsApp group, you just drop a message. I will send you again. Okay. So you can just note down the number. So okay, thank you very much. And inshallah, we will continue tomorrow. Okay, bye bye.